Hi, everyone, and welcome to the October webinar for the Society of Pediatric Psychology's Diabetes Special Interest Group. We're so glad to have all of you here today to hear a wonderful talk from Dr. Korey Hood on diabetes technologies and patient preferences. Before we jump into Dr. Hood's talk, I want to draw your attention to a couple of new things that have come out from our SIG in the past few months. So first, we launched a new website. We hope you'll visit us at sppdiabetes.weebly.com. We have a great set of resources up on the website, assessment tools, resources for families, and resources for trainees. We will be expanding our resource databases in the coming months to include more intervention and parent resources, so keep an eye out for those. We also launched a new social media feed. We have both a Twitter and an Instagram. So go ahead and give us a follow at SPP Diabetes Sci. We have a new resource corner that we share resources on Fridays, and we have some additional programming to better share with our community about all the different people who are engaged in psychosocial diabetes support that will happen through our Instagram and Twitter feeds. So keep an eye out for that as well. Last, before we get to our talk, I hope that everyone will also plan to join us for our next quarterly webinar on January 28th at 12 p.m. Eastern, where we'll be joined by Dr. Susanna Patton, who will be sharing with us about group telehealth platforms for supporting parents of children with diabetes. So thank you so much, and we look forward to connecting with all of you this coming year through our webinars and through virtual SPAC. Today, we are delighted to welcome Dr. Korey Hood. Dr. Hood is a clinical psychologist and researcher at Stanford University, where he is a professor of pediatrics and psychiatry and behavioral sciences. At Stanford, he directs NIH and Helmsley-funded research projects and provides clinical care aimed at promoting health and quality of life outcomes. Much of this work focuses on understanding the lived experience of diabetes devices and technologies and early perspectives and attitudes about automated insulin delivery. Dr. Hood also works to build programs that promote positive coping and problem-solving skills to prevent diabetes distress and depression. In addition to publishing over 100 scientific articles, Dr. Hood is the author of 2 books, Type 1 Teens, A Guide to Managing Your Life with Diabetes, and Teens with Diabetes, A Clinician's Guide, and remains active with programming for the American Diabetes Association, JDRF, and Children with Diabetes. Unfortunately, the first 2 slides of Dr. Hood's presentation were not properly recorded. So before we jump in to the live recording of Dr. Hood's talk, I want to note a couple things that were skipped over. First, Dr. Hood shared his conflicts of interest in this talk, both research funding for an investigator-initiated project from Dexcom, as well as some paid consultant and speaker fees. Dr. Hood also shared with us an overview of the main points that he planned to cover in his talk today. We'll launch right into his live talk where Dr. Hood is sharing with us about what makes diabetes so hard to manage. And after that, he'll share with us about devices and technologies and how they can be effective tools, but only when we address barriers. And also a discussion about how biases exist that create disparities in access to health technologies and how we can better advocate for youth and families with diabetes.
The basic way to do it is either with a vial and syringe or with an insulin pen, and then there's also a glucose meter that's involved. And this is what's been around, and what I think many of you who've had any kind of interactions in diabetes clinics will know these pieces of it. As we get a little bit more advanced, I think that there are a few different pieces here to talk about. One is an insulin pump, which the way that it works has not really changed that much in the last couple of decades, but is a different way of infusing insulin and getting your insulin. And then on the right side about knowing your glucose, continuous glucose monitoring has really been one of the major, I would say, things that has changed how we think about diabetes and how it's managed and how people perceive, the ability to manage it. Has been one of the biggest game changers of the last decade or so. And in here, you're getting insulin, you're getting the glucose values through interstitial fluid instead of checking with a finger stick. And so it's and many of them now, you don't actually have to do finger sticks to do it. So there's going to be a generation of individuals diagnosed with diabetes now, type 1 diabetes now, who never have to do finger sticks, which is certainly something that I think many of us didn't think would happen. So, and then what's in the middle is the integration or the kind of synthesis of those two pieces. So having an insulin pump and CGM, and then having some kind of app or some kind of program that operates an algorithm that based on glucose readings and the speed and the direction will then change how much insulin is being given. And it's a pretty, the algorithms are complex, but it's a pretty basic concept of when glucose values are going up, we give more insulin. When glucose values are going down, we pull back on the insulin. So I'll talk a little bit about what we understand about how well they work and the perceptions of those. So when we think about who is using this and what's the proportion, I wanted to highlight this slide just to give you a sense of this is data from a large registry in Europe, and then there's a large registry in the United States about type 1 diabetes called the T1D Exchange. And we know that across the entire population of type 1, you're gonna see different things between 55 and 60% on pumps. And that may be what it's like in your clinic. It may be what you've become familiar with, but yours may be lower or higher. And then right now we're probably in the 30 to 35% range of people with type 1 diabetes being on CGM. What's important to consider though in these two figures, in the top one, and this is also from the same paper, where we're seeing the biggest increases. And these are most relevant, I think, to us as we work with pediatric patients and families. If you look at the very top panel and then the top line there with the circles, this is the youngest patient population, so under 5. And you see that, back several decades ago, nobody was using an insulin pump. And now almost 90% of this patient population is using it. And you're gonna see slightly lower rates in the US, but this is also where the biggest surges have been in terms of use of pumps. And so that top panel is about pumps. The second panel, B, is about sensor augmented pump therapy, but it actually highlights, because CGM is a component, it's actually the same figure as one that I could show later. But you see these groups, the youngest ones, and so these are often parent-led decisions about using these kind of devices, and there's a lot of reasons why it's become very popular in pediatric patients, both their from their perspective as well as parents. Now, if you think about like the 10 or 11-year-old that starts to have a little bit more input into whether they want to use it, you start to see some declining rates and into adolescents and young adults. And so the reality is that our biggest surges, the biggest use areas are in the youngest patients. And as they get older, and particularly adolescents, you're going to see rates that become a little bit closer to what you see in adults. So with all of that said, so we have a lot of great technology, but when you look at outcomes from a management perspective and who is using devices, only 17% of youth and 21% of adults meet the American Diabetes Association targets for A1C. So A1C, I think most of you are familiar with that, but it's a marker of what's been going on in terms of glucose management over the last 6 to 8 to 10 weeks. Generally, it's done quarterly at the pediatric clinics, and so these rates are fairly disappointing and sobering. And so, and I think that one of the issues has been that sometimes we view this as an issue with the patient or the family, but I think this is a system failure. This is a healthcare system failure that we're not, we don't have enough people that are achieving the outcomes that we think are most important. And when you look at, I wanted to show this. This is a slide from a couple, or this is a study from a couple of years ago in JAMA Internal Medicine. And this is looking at what's changed. You know, we have different treatment options, medications, technologies from 2005 to 2016. And, you know, I think that if you can just take a second and look at the conclusions and relevance, you see diabetes care cascade in the United States has not significantly improved in that time range. The study's findings suggest that gaps in diabetes care that were present in 2005 are still there. And this is particularly the case with younger adults, women, and non-white individuals. So, you know, I'm not trying to make us even more stressed or depressed than I think many of us are at this point. But the reality is there is a system failure here. We're not doing a good enough job in helping people achieve the kind of outcomes that lead them to having more years of life and better quality of life in those years. One point I wanted to make here was, and this is from a position statement on type 2 in youth that we'll talk about in, I'll at least show you the reference for it. But I think this is a really important thing to consider, which is most youth with type 2 diabetes come from racial and ethnic minority groups, have low SES, and have a family history of diabetes. So if you think about youth with type 2 diabetes, they're most likely to match this slide in terms of what you see in terms of outcomes. And that's pretty disappointing that, you know, we have people that are being diagnosed even younger, and then they're going to fall into this, what looks like a system where there are still major gaps in diabetes care and poor outcomes. So with all of that said, let's think about a little bit of what the evidence is for devices. And I've just highlighted it here. There are many citations that we could add here, but I just want to kind of, this is my read on it, my synthesis of what we know, particularly in type 1, but also there are increasing numbers of individuals with type 2 using insulin pumps, but it can lower A1C, so it can help people get closer to the target range, and often improves quality of life by giving them a little bit more flexibility, allowing them you know, access to things that maybe they weren't able to do before. Insulin pens, this is particularly the case in type 2, can increase frequency of injections and satisfaction. So when you move someone, say, from a syringe to a pen, you can usually see some improvements. And then the bottom part here, again, around insulin delivery, thinking about closed loop, you can often get improved time and range. And this time and range is an important concept that you'll hear more and more about. But it's really how much time can we get people to spend in the target range of, say, 70 to 180. Sometimes it's thought of 70 to 150. But those, the kind of typical adolescent is probably only going to be in the, like, 30% of the time is going to be in that target range per day. And so if you think about being able to increase someone's time in range, even from 30% to 40%, that's a pretty sizable amount of time. That's 2.4 hours more a day that they're in range, which has a big benefit on quality of life and health, obviously. So this time and range is a really important variable that you're going to hear more and more about as kind of the this area of diabetes technology and devices evolve. And obviously, you know, checking glucose more often leads to better outcomes. And we know that for those not using CGM, it's still checking more is much more beneficial. And then using CGM in itself, and, you know, 8 to 10 years ago, these findings weren't as clear as they are now. Systems have gotten better. The user experience with them has improved. And so really now using CGM tends to improve time and range, A1C, and quality of life. And most people report that, even in the kind of the skeptical adolescent range, there's still a lot of benefit that comes from using them. So if we've had this pretty sizable change in, you know, devices and them getting better and more people using them, then why aren't we seeing improvement in population outcomes? There's a lot of reasons for that. but I'll talk about a few things. One is, and this gets at the second part of the title, really thinking about patient preferences. I'm not sure that we're doing individualized care. We talk a lot about it. We talk a lot about patient-centric care, but I'm not so sure that that's what we're doing. And so we'll talk a little bit about that. We don't always address barriers, and one of the biggest ones is access. And we need some better tools for doing that. And I think that there's often a mismatch between a device and a person. And I think that, I certainly advocate for trying for everyone having access to these devices. Not everybody's going to want to use them, but everybody should have access to them. And then to think about, but there should be somewhat of a matching to what the person needs in their life. I was presenting at the ADA scientific sessions over the summer, again from an office at my house. But one of the things that I found a little bit disappointing was looking through some of the position statements and standards of care over the last decade, essentially, about how often individualized is used and how often is that term, kind of this patient-centric idea, focused on. And you can see that the best group are our kind, thinking about behavior change. We talk a lot about that, but when you look at the diabetes technology standards, it's only talked about one time. And so there's still this one size fits all approach and a number of systemic biases about who's going to respond best that we need to do some more work to break down. Now this is with adults. I have some data on teens and parents in a minute, but this is some work that we did, and one of my colleagues, Molly Tannenbaum, led this, where we looked at barriers to uptake of different diabetes devices and technologies in 1,500 adults with type 1 diabetes. And if you've seen me present at all in the last few years, you've seen these slides, because I think it drives home a couple of important points. One is that people talk a lot about the potentially modifiable barriers and the things that we could do better, both from a design standpoint of the device as well as in supporting them. So people talk a lot about hassles of wearing devices all the time. They don't like having devices on their body. They don't like how they look. So these are things that we can do much better with in both our onboarding of people as well as giving them trials of it. And it's on the device manufacturers as well to create products that are not as, don't generate as much of a hassle as these do. What was interesting, we also have data on about 500 teens and their parents where the hassle of wearing devices was the most frequently endorsed. This was cut across adults, adolescents, and parents. So everybody's talking about how much of a hassle it is to have these on their body. And then followed closely by this, wearing them on the body. So the sensation of it, the way it looks, all of it is a hassle to people. And these are the reasons why they stop using them. And so these are things that we should address up front. Adolescents endorse worries about what others will think nearly twice as frequently as adults. So this is not, I think, surprising to anybody. But they also were much more likely to endorse that than parents. Parents didn't perceive that as a major barrier. And so when we're thinking about a decision for, say, a 12-year-old to put a device on their body, it needs to be a shared decision between the parent and the child about whether this is the best fit. Point there was that 1 in 5 adolescents and adults said that they didn't want to allocate more time to managing diabetes, but that was rarely endorsed by parents. So again, this kind of comes back to different perspectives and the need for us, even in these younger kids, to ask the kids what their preferences are for doing this. So I'll take just a couple minutes to talk about closed loop. And again, I want to highlight, you're going to hear different terminology for this: closed loop, automated insulin delivery systems, artificial pancreas. And then there are kind of brands within the bionic pancreas and others. So you'll hear about these different systems in different ways, but all of them are trying to automate the delivery of insulin. And some have an extra component called glucagon that is used in them, but most of them are insulin only at this point. So, this is from 2016, and we've updated this, but we did interviews and focus groups with over 300, kids, adults, parents, partners, to try and understand what they expected of these systems. And there's a lot of data in that paper, which you're welcome to go to and look at. But this was, I think, the main point and the most compelling to me, is to think about the group differences. What would people say are the biggest things that they think about in using closed loop or automated insulin delivery? The kids, so these are, and as we categorize them, they really range from 6 to 11 or 12. They were focused on specific social situations and settings such as school and friends. And again, this is pre-COVID, but they were thinking about, how is this going to impact my friendship? How is this going to impact my play date? How is this going to impact how I sit next to somebody at school? Adolescents, on the other hand, were much more focused on wearability and comfort. So again, kind of back to that hassle factor, the physical features of it. And adults and parents were focused on device safety and reliability. So again, thinking about, as you're wanting to encourage the use of a device in a pediatric patient, the pediatric patient themselves may have a different perspective, whereas the parents focus on reliability and making sure that the device is safe. And partners talked a lot about trust and control themes, which also were highlighted in some of the things that parents talked about. So a couple of points, and then I'm going to try and wrap up so that there's time for questions. So what are some ways that we can approach or that we can fix this? I think that the solution in part lies in devices and technologies and broadening access for people. I think we have to think about our approach, and are we truly, every interaction we have with somebody, are we truly doing an individualized, tailored approach to understanding what their needs and wants and perceptions are? And then again, thinking about equitable access, trying to make sure that we're doing a good job with engagement. And part of that is, from the very beginning, trying to match someone's priorities and interests with what a device has to offer. This is from a couple of years ago now, but I think it's probably only been more pronounced. This is from the Pew Research Center, and this highlights the percent of US adults who said what's contributed the biggest improvement in their life, to life in general in America over the past 50 years. And you can see technology above everything else. This is the thing that people talk about as having the biggest impact on what's changed in their life. And when you ask them what's going to have the biggest impact on improvements in life in America over the next 50 years, they talk about technology and what we're going to get from medicine and health. So the reality is that we have people who are interested in technology, think it's going to have a big impact, and are and generally pretty positive about its potential for making some positive change in their kind of small community and universe. And I think we need to capitalize on that more so than we do. And this cuts across different racial and ethnic groups as well. When you look at, and I think just the first set of bars there is to what you can focus on. But when you think about smartphone users, which we know is just steadily increasing, and particularly in the adolescent and young adult age group, I mean, we're at 95% of them are using smartphones or have access to them. But across these different groups, cultural, racial, and ethnic groups, you can see that people are pretty consistently using them to find health information. And so we have another entry point to helping individuals. And I don't think that we capitalize enough on this aspect, that this is something that cuts across communities, that they're interested in using these tools and digital content. So from an approach standpoint, I think that an appropriate mindset is that we think about devices for all. That this isn't, we've evolved in the time that I've been in practice to doing assessments about the fitness of somebody for using a pump, or the readiness of someone for using CGM. And I just think that we need to flip that completely on the other side, which is that we should assume from the beginning that everybody should have access and be able to use this, and then we need to tailor how we support them. And so I think that as healthcare providers, we really shouldn't be the gatekeepers of devices. And so this is a place where you, maybe as a psychologist working in a clinic, or you may not be the person who's making the decision about what someone goes on there, but you can certainly be an advocate for them. And also in as polite a way as possible, challenging any kind of notions about who is this really a good candidate for this. I think that some of those notions are antiquated at this point. And so I think we're both capable of trying to individualize care, as well as having this kind of devices for all mindset. And I think this is, again, an area that we can commit to advocacy to close the disparity gap. And that's by, arguing for broader access to individuals, lower SES, minorities, who wouldn't necessarily be offered these kind of devices and technologies first. And so I think that that's a big area for us to work on. Quickly, I'll highlight one of the things that I find helpful is to try and categorize the type of barriers so that I can figure out what to do with the family unit or the individual I'm working with. And I tend to think of them maybe across these 5 categories, and I think there's a fair amount of overlap, but I think about them as, there's just inertia sometimes that, you want to maintain the status quo. You're either doing it knowingly or not. And then knowledge, unsure of the need for change or how to do it. Skill deficits, might be interested in changing or using a new device, but the set of skills isn't there. So you can imagine that in knowledge and skill deficits, you're probably going to team up with a diabetes educator. You're going to team up with somebody to make sure that their information, that they become more aware. You can use different resources that I'll talk about. And I think, when you think about skepticism, that's where you explore, what are some reasons why you've been uncertain or not wanted to do this? Are there things that have happened in the past? This is where our skills as behavioral scientists and clinicians can really become critical to helping people kind of step through some of these things that they're skeptical about. People perceive changes as too difficult. They perceive the setup, what it's going to involve potentially is too difficult. And so that's another area that we as mental health providers really have, we're the ones to go to for many of these barriers, and where we probably don't insert ourselves enough into these situations where we can help them with barriers. So to wrap up, I think that there are a lot of opportunities to change the narrative on costs and access, and we can do that through advocacy on these kind of small ways, talking to your colleagues, your other providers in the clinics that you work in. You can do it on a small scale, you can do it on a larger scale with different kind of diabetes groups. But there's really and this is coming out in some of the newer closed loop and CGM studies, that people who are on multiple daily injections, going to CGM, going to more advanced closed loop, they're doing really well. So this, our notion that you have to, go in kind of a phased way to the most advanced technology, I think is a myth. And I think we need to do a little bit more to make sure that we can demonstrate the value to everybody. I think that we have a lot of opportunity to, all the data that's generated both on individual characteristics, their perceptions about diabetes, the amount of distress they have. We can use a lot of that data to understand when people may discontinue use, and we can intervene early and before those happen so that we can actually prevent this discontinuation, which we see in a number of people. We see it less in pediatrics, we see it more on the adult side, but still it's an important part that we need to focus more on. I was going to highlight just a couple of resources. So one of the things that we created through the Helmsley Charitable Trust funding, so completely unconnected, untethered from any kind of device funding, any manufacturer, any diabetes company, is a website where you can compare different diabetes devices and then prioritize what might work for you based on, a short quiz we have on finding different things. There's a feature where you can, a little bit like I'm assuming that everybody has purchased something on Amazon where it also says, other people have bought things like this and you can compare and contrast them. And so we wanted to do the same thing here. And again, we're not connecting this in any way to device manufacturers so that it can be an unbiased, unbranded resource for people. So this is one resource that I think you'll see it's geared more toward adults, but I think we've worked a lot with parents who found this to be a really effective tool for them. And then I'll highlight these three, and I think you'll be able to see this on the recording, but I can also, we can at least share the slide, if not all of the slides would be available. But I think that these are three important papers that are good to look at. I was part of the writing group for the psychosocial care position statement, which came out in 2016. And then there's two other papers that came out in 2018, one on type 2 and then the other one on type 1 in pediatrics. And I think that these are really good resources for you to both understand the backdrop of diabetes, the different types, but then also understanding different management options and what we kind of know at this point. And with that, I will say thank you. I'll stop sharing my slides, and then there's probably questions or ready for some discussion.
Yeah, so everyone, please feel welcome. I know often folks like writing in through the chat feed questions. I also, on your registration forms, there was an option to add questions. And so I'll get us started by going into some of those questions that folks had, but please feel welcome to either unmute yourself on a pause and voice a question or write in on the chat with questions. So one type of question that we got from multiple people joining us was around how to better support kids and families who are very, very frustrated by alarm fatigue, device errors, kind of how to support assuming that that might be a reason for disengagement. What can we be doing as psychologists there?
Yeah, it's a great question. And I think that it's, I didn't show a slide that we have on why people discontinue, but alarms and alerts and, the kind of fatigue that comes with that are high on the list. And this happens across parents. Parents tend to be a little bit more willing to deal with it because they see the extra benefit of it. The kids, especially teens, would push to stop using it pretty quickly. So I think there's a couple things that we can do. I think the first part is better expectation setting. I think that we should be part of, whether it's a CGM training course that your clinic does, whether it's a routine visit that they have with you or a social work team. I think we've got to be part of these discussions and insert ourselves early on in the conversation so that we can have realistic expectations or help people set realistic expectations across the board. Excuse me, we see this even, this is more pronounced when people think about using closed loop. They have very unrealistic expectations about what's going to happen. People think that they can put it on and it's going to fix everything. And there are parts of it that it does much better at, but we need to do a better job of helping them set realistic expectations. So I think that's the first part. I think the second part is in working with you have to work closely with whoever has started the CGM system to understand where they're setting the alarms and the alerts. the all of them are changeable except for the ones that have to be there for safety reasons. And so there's only a couple that are unchangeable. All the rest of them are able to be changed. I think many times people feel like the parents feel like they shouldn't make these changes, but I think as someone who could be working with them, I think encouraging them to speak up, to talk to their educator, talk to their nurse, their provider about making some changes. And then you can work with them in kind of a tempered way about changing some of the alerts. There are plenty of alerts that don't need to be on, and it's really easy for fatigue. I think that the other part of it is it's also picking the right time for these alarms and alerts. If somebody is sleeping, I mean, I think that's a critical time, but you can also switch some of them off during the day as blood sugars tend to rise a little bit higher. So those are, I mean, I think the two main parts: helping set realistic expectations at the beginning. And then the second part is actually working collaboratively with your diabetes care provider on making some of those changes and recommending easing off some of them so that you can actually have, can avoid some of this alarm fatigue.
Yeah, thank you. So another question that came up repeatedly on the registration forms was asking about kind of best methods for psychologists getting involved in care to support families who are using versions of like Riley Link or other closed loop systems that may not have kind of approval of their physician, but you're working with the family to support them, kind of ideas or strategies for how to approach best practices for approaching that.
So, so are the questions about, to kind of shorten it, is it about when they're doing something that's off label or not, not prescribed per se, how do you support them? Is that kind of the idea?
Yeah, I think there were a few questions, some just around, are there benefits to using these? Is it, a good thing that they're doing these things? Some around, how do I integrate that within my practice to best support a person with diabetes? So I think kind of on both sides.
No, those are all really good questions. So to give a little bit of quick background, so we have FDA approved closed loop systems, and right now the ones that sit on the market there's the Medtronic versions, and there's a new one that just came out, and then Tandem has the Control IQ. And so these are systems that, and then there are others that have been approved in Europe, but these are systems that have gone through the pivotal trials and made met all of the criteria for FDA approval. So, and then over the last decade, there's been a movement by patients, and largely kind of in this we are not waiting mentality or to do it yourself, that we're just not waiting for all of these different device manufacturers and studies to happen, that we have ideas and we can do this on our own. And so some of the popular systems are one called Loop, one called OpenAPS, and then there are a number of other ones that have kind of been cobbled together by people. But there are probably in the US, I mean, we've estimated this through a couple of our studies. I mean, there are tens of thousands of people that are using these systems, and we've had people that are using these systems on a 1-year-old who was recently diagnosed. So I think that, so I'm certainly biased on the perspective that these systems can offer a lot of benefit, and we've done some studies on them, and there's plenty of data to suggest that they do. What also is true is that many of the people that are using those are kind of unique. These are not the kind of run-of-the-mill people that you might find in kind of your average diabetes clinic. These are people who are, many of them are engineers, many of them are able to do this and think through it and be responsive to it. And there's no way to tell them to not do this. Not that I would, but so I think that it's a unique group. So I think we don't know enough yet if this is ready for everybody to use. And so I think in my discussions with people that, and again, this kind of goes back to what I was talking about with, laying the options on the table for people and helping them kind of move in one direction. I think that offering all of those things, but being equally supportive of the FDA approved ones as well as these do-it-yourself ones, I think is the way to go. And I think that what we have run into are plenty of medical providers who don't want to support this and or don't want to support the use of something that's not FDA approved. And some of the things that I say back to them in defense of the people that decide to do it are that, I mean, you make recommendations about how much insulin they should take, but they go home and they spend 99.9% of their lives administering the insulin and changing the doses. And so that's technically off label as well. So it's a kind of maybe it's a long-winded answer to say that I think there's a lot of value to using these systems. I think that the people that are using them tend to be more tech savvy and proficient with this. And so when you're thinking about somebody who's potentially wants to use it and maybe isn't super tech savvy, I think that that's where we can add some help to them by, sending them to websites to figure this out better, but also to, have a slower start to it and to support them as they go along.
Yeah, so a couple questions that have come in, I'm going to frame in the context of some that were asked. So we had a lot of questions that I think you talked about or you referenced within your talk around what happens when patients are forced to earn, technology, and this notion that everyone should have access. We need to move towards that state where, patients and families aren't having to earn that tech. And there were also, questions that came up around kind of what does this look like in practice? So as we move towards a place of saying everyone should have access, do you have examples from what you're doing in your clinic around like a process for kind of onboarding in pumps, or a process or surveys or tools that you're using in clinics to identify expectations and barriers, or to help get around the readiness questions that sometimes come up around earning devices in clinics?
Yeah, those are good questions, and I'm trying to think about how to kind of frame my ideas on this. I guess I would say at the start is to you're always going to be a better advocate within a clinic setting when you have data and when you understand what's been published and what's in the literature. So you absolutely have to stay current with what's out there. As an example, we have a grant from NIH from NIDK to systematically start everybody in our pediatric clinic on CGM. And so, at diagnosis. And so within a month of diagnosis to start people. And, there are people that can opt out. Most people opt in. And so, and there's emerging data from other clinics about doing this. And so starting these devices earlier on, making it part of a systematic program of how you deliver care, I think we're going to see more and more of that. And so that's going to be one major tool that you have to advocate for changing your clinical practice to view it as this should just be standard of practice. We should give people the opportunity to use this. So I think that that's one way I would do it. I've worked in 5 different pediatric diabetes clinics, and everybody's had a little bit of a different notion of how people should access it. I don't think that there's anything wrong with if you're in a place where they still want to do kind of the readiness questions and they want everybody who's starting to do it. Absolutely. But in your mind, from the beginning, you're assuming that this person is going to be able to do it and that they're going to have access to it. So even if you still do pump evaluations and you still do CGM evaluations and people have to kind of go through steps to earn the right to use it, then as long as you change your mind to have an approach of, I'm going to find a way to help this person get on it. And so that may be that you realize, I'm probably going to have to do 2 or 3 sessions with them before they start on something to make sure that I can get some of their worries about diabetes down before they start. There may be other things that you want to do. So your treatment plan is going to be really important in those situations. But again, keep the mindset on, we can do this for them. I guess I would say that I haven't had a lot of luck changing people's minds who have been doing this for decades. And so I think that that's why I think that trying to, sometimes instead of changing an individual like gatekeeper of devices, the go-to person in the clinic who makes all those decisions, it's sometimes better to think about how you can change the broader system, kind of the approach to it, instead of changing that individual. And that's why, we've done work on program improvement with, psychosocial screening within clinics, and we've gone to get support from the hospital to do that. We've gone, and we get these external grants to do it. And so I think that there are ways to do it. It's not always going to work, but I think that, you're always going to impress people with more data and more studies that show that what you're doing is the right way to do it. And so that's really where I think it's a critical place to start.
Yeah, there were a couple of follow-up questions in this, Korey, around, are there recommendations, or is how do behavioral health teams become formally involved in readiness assessments if they're happening in clinic? Are there tools that you would recommend that psychologists or a behavioral health team could use in engaging in that process to support identifying expectations and barriers? Is there data to support the behavioral health team becoming a part of that process? Kind of how to, what is this current state of tools and assessments and things that we can already integrate into our clinics?
Well, I think that, the psychosocial care paper and then the follow-up ones that I provided, I think have some good resources for ways to do that. I think that I was looking through the resources on DSIG's website. I think there's also great tools on there in terms of thinking about assessments and readiness. I think, I think if you're in a position where you're part of this, I often think that the 2 main things that to assess for are some level of barriers. And so it's even just, a quick assessment, you don't have to use necessarily a validated scale, but just thinking about, what do you think is going to change about your, what's your body image going to be like? What's your, how is it going to feel to have this on your body? I think a barriers assessment is really critical as part of this. And then also some level of diabetes distress burden, and this is really different from depression and stress more generally, but getting that, and there's great tools for that. On the pediatric side, there's the ones that Joe Weisberg-Benchel has created, that Jenna would know well, and I think are free to access. I think they're all free to access, and we've done some work around using closed loop, and also with Jill and her team, and that's on our diabeteswise.org website, and it's free to use. So there's a lot of tools that are floating around. Diabetes distress scale from the Behavioral Diabetes Institute is a great tool. And we've even used that down into adolescence. And so there's a lot of great tools that you can use that give you a little bit of a sense of, I would say, barriers and this kind of level of distress before you start people. I think that that's a great thing to do. And then maybe that's, I think that the other maybe critical point is to insert yourself into these, any kind of introduction to diabetes. You're new to diabetes and we're doing a group class. And again, it's probably taken a slightly different format because of COVID, but insert yourself as a behavioral specialist into those trainings for families. Insert yourself into anything when they're doing a pump training, get involved in that. And what I mean by insert is that if you haven't been invited, then invite yourself. Don't wait for an invitation or wait for someone to think that it's important. Most of the time people don't undervalue what we do, they just forget about us. And so I think that you have to put yourself out there and make sure that you're front and center and part of those discussions, so that it can be, so that the behavioral side can be evaluated and heard. And then and also people see it as just kind of a just a regular part of clinic to also see the psychologist or social worker.
Yeah, that's wonderful advice. I think the last kind of set of questions that I'm wondering if, you mentioned that Diabetes Wise is a bit more focused for adults. There were quite a few questions around, like, when you have teens with that whatever attitude toward kind of mindset towards type 1 diabetes, who are like, are there any new technologies that are better to get patients going on when they're struggling, better choices, things to aim for, things to avoid? And is there anywhere where that information is kind of organized or available at this point?
So I'm sure that there are resources for that are escaping me right now, but I can think through a little bit more. I think that I guess the angle that I would go, and this isn't too dramatically different than working with adults. So just as totally parenthetically, I was trained kind of across the age span, but much more of a specialization and focus on pediatric psychology and clinical. But probably at this point, half of our protocols are with adults and half on the pediatric side. And it's really been nice to kind of see it across the spectrum. But, and now I'm like totally blanking on what the main question was, because I went into a parenthetic.
There were a lot of questions around, like, can you point us to the device to pick for a struggling teen, effectively, a teen who doesn't want to engage? Is there something better to start them on, or something, a worse choice they could make?
Right. And I think that, so I think what I was trying to highlight was that, you're going to find this with adults as well, but I think that teens are a good example of, you have to find, whatever hook it is that they're going to be willing to use it. And you're going to have to spend time exploring with them. They're going to give you 100 reasons why they don't want to do it, but you've got to find that those one or two things that give them some kind of hope that this will be, I'm getting ready, I become more like, romantically involved with somebody. This thing might make it a little bit, might make diabetes like hide a little bit at those times, and that's perfectly fine. There may be, you've got to find that kind of hook for them, and it's going to be specific to the person and unique. So I think in any kind of evaluation, and I tend to not think of it as, I tend to not give, the option of not doing it, even though people can choose to not do it, but I don't present it as, it's much more in kind of a motivational interviewing approach of like, what are the things that we can do to help you do this? And, what's been a problem in the past that maybe we can address right now? It's like the car salesman, like, what can we do to get you in this CGM? But really, like, we have to have that kind of approach and think through it versus giving them an out, because they'll vote with their feet. They'll stop using it if they're not going to like it. Mm-hmm. I know that's not a great answer, but I think that
it fits with your recommendation to really individualize treatment, right? To fully kind of do a thorough assessment and personalize care as best we can. Marissa shared with the group, Hilliard, that she agreed our endo colleagues often don't realize how much we can offer in issues they see as purely medical. And, I think that has come up today in your talk, Korey, but I've also heard it from a lot of pediatric psychologists recently on kind of facing these challenges. So maybe it's something our SIG can come back and return to across time as a group, of how do we help people advocate for their roles in some of these things when they aren't able to do that within their clinic currently as a behavioral health provider. So, well, it is 1 o'clock. So I wanted to thank you, Dr. Hood, for coming to share your wealth of knowledge with us and kind of have this conversation around both individualizing care and providing access to care, and how we can have a really important role in that as psychologists.